Thanks for coming to our talk, everybody. I'm Meghan Pike. I'm one of the oncologists at the IWK. I am the profile site investigator at the IWK, and I lead the solid tumor program at our center.
And I'm Katrina MacDonald. I've been a nurse in peds oncology for many years and now the lead clinical research nurse at the IWK with our team.
And we're here to share with you a out-of-the-box strategy that we created over the last year or so to bring more early phase clinical trials to our center. We worked together to develop a clinical research support team. So really, what were our motivators? So through my learning as the site investigator for Profile, what we found that patients with rare refractory relapse tumors had limited trial options in the Maritimes. We are an active member of Children's Oncology Group. We have over 60 trials open through COG at IWK, but up until now, we haven't really prioritized opening early phase trials. And the number one reason for that really was that we just didn't have the structural capacity or the manpower or woman power to make that happen. So through Profile, as you know, as clinicians, sometimes we see a targetable mutation and we just don't have access to a drug that might be valuable for that patient. And even if a patient doesn't consent to Profile or doesn't participate, or we don't find a targetable mutation, if they have relapse disease, we are having discussions about clinical trials. And one of the biggest things for these families to consider is whether or not they would be willing to travel, and the burden associated with that, especially when quality of life is so important. So we really wanted to work together to find a way to bring more treatment options for patients in the Maritimes.
So like any initiative, like the good researchers that we are, we began a scan of the literature to look at others' experiences in establishing a clinical trials team or unit or office. We then applied that evidence to our approach in the development of our team. And I will say there is not a lot of literature out there on this subject, but we did take what we could and we really found commonalities and then followed that stepwise approach.
And so how did we get here? So I think, the identified need was the lack of access to interventional therapies and early phase therapies in the Maritimes. And we really felt that this was the right time to start bringing more trials to our center, where we were experiencing some uncertainty with international funding through COG and other that we've talked about a lot today. And so overall, we felt that in the Maritimes, we had a lack of access to these early phase trials. You may know the IWK cares for patients from 3 provinces in Canada, so Nova Scotia, PEI, New Brunswick, and so we're the only tertiary care center for those patients, so we represent a large geographic area and also some of the highest rates of poverty in our country. And as we saw this morning, patients with lower socioeconomic status often have that as a barrier to entry into early phase trials. So Katrina and I basically met around a year ago and said, we should do this. And then we just wrote a proposal and we gave it to our division head and we gave it to our department head and then we gave it to the VP of research and then we gave it to the foundation and we just said, look, we're just going to do this. And that's kind of what we did. And so far we've hired 2 clinical research nurses, so CRAs with nursing expertise within our group. We've secured pharmacy support and administrative support, and we've opened 1 early phase clinical trial and are in the process of opening 2 more.
Woohoo! Woohoo! Yeah. Yeah. And of course, I always have to put the plug in for nursing and say that we have also been able to support the beginning of 2 nurse-led, nurse-driven research projects. So we're happy about that. We, of course, began by identifying our core values as a team. And I want to back up and say that part of what we did when we were in this process was we involved a couple of parents and of patients. And one of those parents was a bereaved mother, and she helped us with identifying some of our core values and helped us in particular with developing some documents that we are using for fundraising. And one of the things that she said that will stay with me is that when her child was going through treatment, that being close to home, his community, his friends, and his family, that was actually part of his care. And being with those people was part of his care. So that was, in a result of that, was that our mission statement is to support high quality research so maritime kids can make more memories at home.
So this is our sort of organizational structure of the clinical research support team. Katrina and I are in the middle there. So myself as medical director and Katrina is our lead clinical research nurse coordinator. So we lead this initiative. We have 2 clinical research nurses that work with us. There's also a regulatory nurse specialist who's a CRA hired through COG who sort of bridges the gap between the research priorities in COG and us so that we're not overlapping our efforts too much and we can support each other in our initiatives and use the same SOPs, which has been great. We have secured administrative support for our team through the division and then identified a pharmacist who helps review drugs as part of the protocols for these clinical trials to see whether or not it's feasible to administer those types of medications at the IWK. Katrina and I report to our division head, who then reports to our department head, who are all supportive of this project. And those are really the people in your institution that you need the initial buy-in from to move this forward. Not included on this slide, but very vital to our work are the people that provide like external advisory to our work. And one of those people is a PWLE who reviews our trials. Once we've done an initial feasibility assessment, they review it for their comments and really give us some advice on how to best approach patients with discussing these trials. And then we've also sort of appointed an external advisory board of legends in the field of oncology, like Conrad Fernandez and Tina Bocking, and people that have mentored us over the years to just provide their kind of bird's eye overview, some advice and wisdom for us as we go along.
Is there a nomination process for legends in the field?
They are voluntold.
They're voluntold. Emphasis on the volun because we don't have any money for them. So I was just hoping that we could each share like a couple takeaways from our work here. One of my biggest takeaways that I want to strongly express today is just how much you can get done if you work with a nurse. So if you need to get stuff done, you need to work with a nurse. They have a crazy amount of skill diversity. They're very task oriented. They're passionate about the patients that we serve. They know what patients need. They are the ones that are giving the drugs to these patients. They understand what the needs are and they have knowledge above and beyond the clinical landscape. So I have never so far in my experience worked with anybody that can get stuff done so fast as a nurse. So really, I think sometimes as physicians we're protective over our work and sometimes afraid to delegate. But one of the biggest barriers to getting anything done is time. And if you don't have the time, then you can mentor somebody else to work with you to accomplish the same goal. The other big takeaway was advocacy. So what I realized is when I started, talking to the foundation and to leadership at our institution about, we're trying to fundraise for this, for our ongoing efforts. And I would tell them these statistics about pediatric cancer and stories about the patients that we serve. They honestly have no idea. And so it's really on us to share the stories of our patients because this type of work changes our conversations with families whose children have relapsed disease from this has happened, it's not curable, we don't have any treatment options here to here's what we can do at the IWK to further support you, which is a completely different conversation and leadership really needs to know that and hear the story from our perspective.
And one thing I'm gonna just back up and say about, I'm gonna chime in with Meg's takeaways here is that I think that I'm gonna ask, are there any nurses here? So there's a few, there's a handful, and we know that nurses make up about 50% of the healthcare workforce, yet clearly there's a small representation here at ACCESS, and this is where change is happening in cancer care across the country. So I'm really hopeful that we have, all of you can make friends with a nurse and bring them with them and parents with that different representation. But when we were doing our literature search and our literature review and trying to plan how we were going to do this, there's certainly ample literature on the role that nurses play in the delivery and implementation of clinical trials. But I was not able to find anything on the role that nurses play as leaders in the development of a clinical trials unit. So I think that's something that we're doing here in our kind of co-leadership and development is unique, and I think what has also facilitated our ability to get things done. So my key takeaways, we are all mentioning, and I think pretty much everybody is mentioning that we certainly are at a unique moment in time in clinical research in Canada right now due to what's going on south of the border and also internationally. And although that comes with a significant amount of stress and worry and instability, it's also quite an opportunity. And I say that because Meg and I have certainly had to put on our hats as health philanthropists, I suppose, and trying to figure out how we're going to make this effort sustainable. And the language that we're able to use now, I think, really resonates when we tell people that our access to clinical trials for kids in the Maritimes could potentially be under threat and we need to secure some stability. So it is an opportunity for us that way. In terms of barriers, there certainly has been some resistance. I'll speak to my own personal barriers. The biggest barriers have potentially been with nursing leadership. This really did require stepping outside of the box and stepping away from the traditional way of working in nursing. So no longer working in a nursing unionized position, but working solely in research was what was required in order to move this forward. And that was met with a little bit of resistance for sure, but resistance that luckily has been overcome. And then in terms of just the way I like to think about this, I think about this in terms of sovereignty for us in pediatric oncology research. I know that sovereignty is really a word that is resonating with a lot of people right now around the world. It's the right to self-determination. And I think that applies to what we're doing here. And I think about it as structural sovereignty. It is our responsibility as Canadian researchers in peds oncology to be sovereign. And it's also our responsibility at the IWK and in the Maritimes to build this infrastructure, this expertise, and this capacity so that we can serve our community. And I see it as a matter of duty to our patients to support that.
Yeah, so we're hoping we have a few minutes at the end of the session to talk about, we're just interested in hearing what other centers do to open early phase clinical trials. Are there any barriers to opening them at your center? Can we provide any ideas or support, given that we kind of thought outside the box to make it happen for our center? And happy to answer any questions.
So I'm happy to start. So first, huge kudos, guys, for this initiative. It really is impressive, and I think every center has various barriers they have to overcome. So that takes a lot of inertia and passion. So kudos to you guys. So 2 questions, and I say this because, and we can talk more offline, because we've just launched a new clinical trial for at CHEO. Is this only? It sounded like this was only for oncology patients. Is there a plan to branch that out into other disciplines? That's the first question. And second question, around your advocacy and funding, have you had conversations with provincial governments? Because I would think particularly you're in the unique situation that you can maybe play them off each other. If you get one government that's supportive, obviously the other maritime government, and then there may be an opportunity for us to leverage that across the country. But there is that sort of a bit of a competitive spirit around access, but particularly in the Maritimes. If New Brunswick's doing it, then Nova Scotia maybe feels more pressure or that kind of thing. So just wondering about whether you've done that.
We haven't, but we're going to now. That's a great suggestion. No, we've only so far leveraged like executive leadership team, IWK research, and then the foundation.
Because there are MPPs, I remember when I was there, that are and maybe obviously MPPs have changed, but MLAs or that are particularly passionate about.
Absolutely, that's a great idea.
Anyways.
Thank you. And then we are focused on our division, so it's hematology and oncology. we don't have plans right now to include other disciplines within the health center. I mean, open to that, but we would definitely need more, buy-in from some of the other.
I mean, just building on the last presentation, there may be
Yeah.
some rare disease.
Yeah, true.
Groups that may want
Absolutely.
to,
Yeah.
access, especially if you've set up the
Infrastructure.
yeah.
Yeah.
Yeah, and I'll just add that this was a question that came up in our last session. Somebody asked whether we were really exclusively focused on access to early phase clinical trials, or whether we were also supportive of like investigator-led research, clinical research. And the answer to that is absolutely yes. So that's part of what we're here for, is to have the infrastructure in place. So that offers that opportunity to investigators, and certainly I can see that overlap being something that might come into play there.
Yeah.
The other funding source, and we can talk about this after, is, the ability to, get pharma funding, obviously,
I know.
right?
Yeah.
And
Yeah.
have that
Yeah,
be,
industry.
have a bit of return on investment there, so that it
Yeah.
ultimately could maybe be self-sustaining, so
Yeah.
you don't need all the foundation
Yeah.
funding.
Yeah.
So, I'm Gary Sandler, Radolph, who works in the ped space, but also adult space, and reflecting on your comment about non-oncology studies. Certainly in Toronto at the adult hospital, it was the cancer DCRU that started first and was very well developed. And then the non-oncology side, Toronto General, cardiac transplant, they then now have set up a DCRU as well for non-oncology study, and they modeled it after the oncology unit. So you're kind of the tip of the spear here, which is very exciting. And when they set up their unit, they actually poached some of the oncology. So, that's, I guess.
So careful too.
You'll never forget you.
And then certainly on the adult side, the menoncs are rolling to the radoncs anyway, rolling in money because they get all this pharma money for breast cancer, colorectal cancer, melanoma studies. It's harder for kids, right? Because it's rare
Numbers are low.
disease and smaller numbers, but if you can leverage that, that's very exciting.
Yeah.
So great work.
Thank you.
I've been encouraging Katrina to publish our methods in developing this so that, like you said, maybe we could spearhead it for other people, which would be really fun. Yeah.
We got about 2 minutes left, so we got time for one more.
Yeah, so maybe I'll chime in a little bit on this sovereignty aspect within a hospital. And I will share my experience at the Jewish General Hospital in Montreal, that sovereignty sometimes comes with some challenges with respect to buy-in from the hospital with resource allocation. And I'll give you a specific example. So in hematology, you've got all these great therapies, you've got bite technologies, you've got CAR-T. But if you're not aligned to the ICU, you've got a big problem, because the ICU could be a visit for some of these patients, especially within the first 24 hours. And so we had to make our partnerships much stronger with the ICU and pharmacy to be able to grow our clinical division. Now we're quite a large division, but it does require feasibility studies within the hospital that we need to consider. And the nurses, we have a similar situation, union nurses, non-union nurses, that then patients have to be handed off to. And this becomes part of the ecosystem in the milieu that you have to think about to maintain something that's really strong.
That's a great comment. I appreciate it. I am thankful that we are a relatively small institution and have been able to cultivate really strong working relationships with our colleagues. And I think we should thank our COG office for that, because that's been something they've been very invested in all along. And so they've really paved the way for us. I think that this wouldn't have been as straightforward without the work that they've done, but that's a great thing to think about. Thank you.